just want to do a few housekeeping points, and then I'll take you through my introduction. So we are going to be presenting some materials to you. So what I'd like to do is, if you can keep your mics on mute, if you're not speaking, that is. But then if you could then save your questions right to the very end of the presentations, and I'll make sure that we've actually got time to answer any of your questions. Or if you've got questions as we go on throughout the presentations, if you'd like to just put them into the chat as we go along, and then we'll pick those up. Is that okay? Right, so I think quite a few new, I want to certainly welcome any new members that we've got tonight. I certainly see some very familiar faces on the call, but we've obviously got quite a few people, and so I'm having to dash between tiles to see who we actually have got on the call. So apologies. So, but do want to welcome new members. I know from talking to Anu that we have welcomed quite a lot of new members actually over the last month or so, particularly since we had our community open day at St. Peter's. So that's just great, actually. It shows great interest in the trust, and I think we really appreciate that. So firstly, wanted to welcome you to our executive team. So Keo, I think you're going to drive the presentations. So here's our very talented executive team. You'll appreciate that, having moved into a group model from the beginning of the year, that we do now have some group appointments. Obviously, Louise is the Group Chief Executive Officer, and Ruth Colburn-Jackson now as our Group Director of Transformation and Digital, which is great in terms of how we moved into the group model. And Chris, who's now our Interim Director of Strategy, has also been working across the trust as well in terms of when we go through our strategy refresh. But you'll be hearing from all of these people this evening, so I'll let them actually talk for themselves rather than listening to me journeying on. Keo, can we have the next slide, please? Okay, and these are the non-executive directors, and here we've got a real blend of experience from 4 very experienced clinical NEDs in the 2 Janes, Julie and Andy. Chris Kane has got a real background in terms of estates experience from his time at BBC. Simon Devonshire, who marvelous, he's actually a serial entrepreneur. I've always wanted to be a serial entrepreneur, but he's a real expert in terms of transformation, particularly around use of digital AI, etc. So that's really good experience that we've got on the board. So without further ado, I want to go into the year to date 24-25 summary. Okay, can we move on? Thanks very much. I'm not going to go into all the details in here, but just to say that you probably appreciate, those of you that really do know the trust, that we've been busy. And I know that we've got 1 or 2 volunteers on the call as members here as well. So you'll know the footfall that we get through Ashford and St. Peter's. So these were just some of the highlights. We've seen over 500,000 people in our outpatient clinics. We've seen, as you can see, over 120,000 people in our accident and emergency departments. And we've actually helped to deliver nearly 3,000 babies in our maternity units, which has just been rated good by the CQC. So we've got lots to shout about. I'm not going to touch on all these things. Keo, can we move on? We will be sharing these slides with you, so we'll be publishing them onto the website, so you'll get a chance to take another look at these should you need to. You're probably aware in terms of the sites that we have, obviously Ashford Hospital and St. Peter's Hospital. Ashford really being the Surrey elective centre, St. Peter's being more of the sort of the warm site dealing with accident and emergency services, etc., etc. But I have to make a mention for the Woking Community Hospital. Was there only this week, where obviously we've got quite a lot of community diagnostics going on, but also extremely important inpatient neurorehabilitation services, people post-stroke. So that's an extremely impressive unit that we've got at the Bradley unit. And then obviously in line with what's actually happening around the 10-year plan, we're trying to put as many clinics as we possibly can within the community itself. And you can see a list of the places that we've got there: Cobham, West Byfleet, Hounslow, Teddington, Runnymede, etc. And I think that's extremely important, and we'll be doing more of that as we progress. Have the next slide, Keo, please. Okay, I think you're all probably aware of the 10-year plan and the Prime Minister's announcement on the 13th of March. The abolition of NHSE and obviously bringing things back into democratic control. And this is going to be done over a 2-year period in terms of the changes there. So obviously big changes in terms of both NHSE head count and the Department of Health and Social Security. And it's expected to be cut around about 50% in total, giving savings of around £500 million. So that's big savings that we're expecting from the ICB, and those savings are expected by Q3 of 25-26. And in terms of us as trust providers, we know that we need to make further reductions in terms of our corporate costs to make sure that we're sustainable going forward. And we're working hard on that already through SIPs, etc. But in terms of there's 3 big left shifts in terms of the 10-year plan, from hospital to community, and we were already on that journey anyway, from analog to digital, similarly in terms of our move to an ERP system with Cerner, and sickness to prevention. So yeah, it makes sense. I don't think anyone's going to argue with things that are in the 10-year plan and the Darzi report. Can we move things on, Keo? We were sort of probably ahead of the game with all this, actually, because from the beginning of the year, as I say, we moved into a group model. We were aware that the NHS is changing. We're having further demands placed on our resources, and we appreciate that funding is limited. So we know that we need to be fit to the future, and that we know that we need to really leverage joint scale that we can have by bringing things together and working across a much bigger platform as two trusts. So I think we've got a very clear vision in terms of being very clinically led. So we've refreshed clinical strategies, and certainly across the trust, sharing best practice, standardizing wherever we can, so that we can actually have standardized outcomes for patients too. And so it doesn't really matter where within the trust that you're actually treated, but you receive the same high quality of care and outcome, but sort of seeing the right patients in the right place at the right time. So I think that they're just the things that I wanted to start with. And I think probably at this stage, I'll now hand over to Michael, our Chair of Governors, to give you his introduction. Michael?
Yes, I'm here. Thanks very much indeed, John. If we could just go on to the next slide, please, as you've seen quite enough of me. Foundation trusts. The top bit is what defines us. If you ever suffer from insomnia, I recommend the Health Service Act of 2006, but the bottom bit is the most important. What's different about a foundation trust? Well, the 3 things there are very important. But most important of all, I think, is that a foundation trust is given quite a lot of extra autonomy and how it runs its affairs and how it runs its finances. So there are great benefits of being a foundation trust, of which there are about a couple of hundred over the whole country. And that final point, the board runs the trust. Well, it's really more of a 4-way thing, because we've got the membership in one pot. The membership then elect their governors, and the governors appoint the non-executive directors, and the non-executive directors join with the executive directors to form the trust board. And the movement of information and opinion between those 4 pots is both ways. So it goes basically from members to governors, governors to NEDs, NEDs to the board, and then it comes back the other way. And we have, as governors, quite a good, in fact, a very good relationship with the board. Could we have the next one, please? Now, we've got 3 kinds of governors. There are public governors. Now, they're elected from the basically the area that the hospitals serve. So we've got 3 from Elmbridge, Runnymede and Woking. We've got three and Spelthorne, and 2 from Kingston, Richmond, and indeed those 2 cover the rest of England. So there are 14 in all. There's only 13 pictures here because there's a vacancy in Elmbridge, but that's going to be addressed in the election that will be coming soon, and that's the subject of another slide. So there are our public governors. Next one, please. And these are our staff governors. Now, they're absolutely vital to the working of the Council of Governors, and they represent different areas of activity within the hospital. Gavin from administration and management, Andy, one of our wonderful volunteers, that superb band of volunteers that help at the hospital, Toc, a consultant anaesthetist, who's a pillar of strength to the governing body, Tracy, our nurse and midwifery governor, and I shall be saying a few words about her a little later when it comes to the election time, and Kate Colburn, the allied health professionals, which is a bit of a mouthful, allied health professional, but it means all those therapists, physio, occupational, speech, all those therapists that do so much to aid our patients. And the next one, please. And these are our appointed governors. We have one appointed governor from each of the boroughs that have one of our hospitals in. So we've got Med from Spelthorne, we've got Ellen from Woking, and we've got Mark from Runnymede. And with Mark, we've got a double benefit because he also is not only a counsellor, but he's also one of our consultants in cardiology. So we benefit from that. We've also got representatives from both of the seats of learning in the county, Professor Amy from University of Surrey and Professor Alexandra from the Royal Holloway University of London. So that makes up our governing body, and there are 24 in all. So if we could go to the next one, please. Now we have these duties that are always advertised and sound rather onerous, to hold the non-executives to account. Well, it's not really as harsh as that, but we really are, as a governing body, able to ask questions, and we are very privileged now that we've reinstated the informal meetings with the non-executives, and the first pair of those with 3 non-executives each coming to talk with us in the next couple of weeks. And to represent the interests of the general public, if you want to get in touch with your local governor, do so through Anu, and she will actually put any queries you have in touch, and to represent the interests of the general public and all our members. But you don't have to be a member to raise a query. Certain large transactions, there haven't been any this year. The Trust's external auditors, yes, that's been done, and to appoint the non-executive directors, and that is really our most important role. And we've got an appointment process in process at the moment, and next month we will be looking to appoint 3 non-executive directors. Sadly, our non-executives are only allowed to serve for 6 years, so there's a constant need to replace and to renew the trust board, and the appraisals of the non-executives, including the chair, which has been a very happy and pleasant duty this year. Next slide, please. And what have we done? What have we done this year? Well, we've done all those sort of things. We've had the non-executive director meetings, Council of Governor meetings, which the non-executives attend, and we're very glad that Chris Kane has been able to stay with us for an extra term because he's been invaluable in the transition process. We've done the appraisals, as I've mentioned. We've had 2 new non-execs, in fact 3, because the associate one has stepped up to the role this year, and we've got as I say, an appointment process in progress at the moment. We've been absolutely delighted to ratify the appointment of Louise as the Group Chief Executive. It's been a very interesting time, and I'm much looking forward to her, who's going to speak after me. We've also been very happy to have John Machin as our acting chair. He's done it since January. He's still in post, and he's still going strong and keeping us in order. And we've, as I say, one of our deputy non-executives has stepped up, Julie Pierce, And that's really what we've done this year for our role. It's been a busy year. Probably I found a meeting almost every week. So could we have the next one, please? Involvement. Yes, we try to get involved. We try not to interfere. And that's what the involvement is really great. I was very, very happy to go into the open day that we had. It was a very happy occasion, and meeting the staff in an informal setting was quite unusual and quite uplifting in a way, and to hear the cheerful way that some people with not terribly cheerful jobs actually do their job and what they do. It was quite an eye-opener to chat with a couple of gentlemen from the mortuary. The way they explained what they did was just so moving, and how the care that's shown, even when people have passed away, was very gratifying. It was very interesting indeed, and we have a very nice, good time at that. And of course, the Staff Achievement Awards ceremony, which takes place next week, is a very happy annual event. Can we have the next one, please? Some revisions to the Constitution. That's another duty of the Council of Governors. And the ones we've had this year have been very minor and just tidying up, and actually just making the wording about the group model and the joint chief executive, just making that a little clearer. And that's something. The one at the bottom looks rather intimidating: provision for dealing with urgent matters. Well, actually, that was just a decision that anything very urgent could be dealt with over the telephone or over the internet. So can we have the next one, please? Now, this is the last and, to me, the most important slide, because we've got elections coming up next month, and there are 13 vacancies. There are 11 public vacancies. Now, it's been quite a lot of interest in that, and every member will be getting a voting form and a little resume of the people that are standing for election in their area. Now, there are amongst them some people who are coming up and will be offering themselves for re-election. And without doing any canvassing, I'd like to say that every single person who's been a governor before that's standing for re-election has been a very, very valuable member of the Council of Governors. And then we come to the staff election, which staff elect their governors, and their governors are very important to them. And there's a position for allied health professional, and then there's a vacancy for nursing and midwifery. And this is where I want to say a few words, if I may, about the current incumbent of that role, Tracy Bradshaw. She has been the nursing representative on the Council of Governors for a very long time, but she's decided not to stand again, and I quite understand why. She's done it very well, and she's done it for so long. But she's been an absolute pillar of strength. She has been a huge credit to the Council of Governors. She's been of enormous help to me, and she really is the most amazing representative of the nursing staff of the hospital. So I'm really sad, Tracy, that you're leaving us, but I'm really happy to have had the privilege of working with you. So thank you very, very much indeed. So that's all I wanted to say. And if there are any questions, as John says, let's pop them in right at the end of the meeting. I'll be happy to answer. Thanks very much.
Thanks,
indeed.
Michael.
Thank you, John.
No, there was a very uplifting presentation, and I'd like to add my thanks actually to Tracy as well, actually. So yeah, we'll probably spare her blushes, but yeah, fantastic. Thank you very much indeed for.
I should have mentioned though, John, that the governors would be totally lost without Anu to guide us.
Oh, you just spoiled my thunder. You take my thunder, Michael.
Of strength.
And we know secretly that Anna's the one that actually really keeps us all in order, so it's fantastic.
Absolutely. Thank you.
And I know that she puts in a lot of hard work with this, and I was going to mention her special work at the community day when she actually signed up special additional members, shall we say, actually being very, very, very active there. I won't mention who, just to, again, spare her blushes. Right, thank you very much, Michael. So without any further ado, keeping us very much on time, I'm now going to hand over to Louise, who I think is going to talk us through her reflections on the year so far, and then look to objectives for the strategic objectives for the year ahead.
Thank you, John, and thank you, Michael. It's great to hear how involved all the governors are and how much you support the trust as a whole. And, you know, that does make a massive difference to being able to do these jobs, knowing that you have got the governors who are absolutely out there and being the eyes and ears of our communities and really feeding back to our trust. So for those who don't know me, I think both my previous speakers already mentioned, but Louise Stead, I'm the Group Chief Exec for Ashton St Peters and the Royal Surrey. And I've been in post since the 6th of January. So we've had a really busy and positive year so far, and I know my executive colleagues will be telling you a bit more about the activities. But I just want to give you a few reflections on some of the highlights that I've found since joining Ashton St Peters in January. So we had a really successful community day at St Peters in July, a great opportunity to engage with our local community and showcase the amazing work that we do. And it was also a real opportunity to collaborate with local partners and give them the opportunity to be part of that day. And it was great to see people from the cadets, from local care homes, and from lots and lots of other local services. So really, really great. I'm delighted that our maternity service has been rated good. This is a fantastic achievement from our team, and as you know, has been a real area of focus over the last few years at Ashton St Peters. Pride in Nursing and Midwifery is an annual event and something close to my heart, being a nurse and in fact still being on the register. So I was delighted to open that. Another real focus at Ashton St Peters is the quality improvement process and how we really try and make things better for our patients. It was another great annual event where various colleagues throughout the trust come together and share innovative ideas to solve problems, improve quality and safety for our patients and staff. We have been re-accredited for our Veterans Aware programme, and this trust is really, really committed to helping serving members, veterans and their families. And I know there is a long history of that at Ashford St Peters. The White Ribbon accreditation. This trust has been accredited with a white ribbon, and it's a recognition of our commitment to preventing harassment, abuse, violence against women and girls. And we're one of 7 trusts nationally that's got this. I think I'd just like to say now that in light of the current situation we find ourselves in as a country and a community, we are really, really aware that this is much, much wider than just looking at that from a female point of view. And we are working actively to support our staff across all areas of harassment. Our Woking Community Diagnostic Centre opened in June, giving residents a state-of-the-art diagnostics within Woking Community Hospital. As many of you will be aware, it's a real government initiative to make sure that we can bring diagnostic testing much closer to home. And if COVID taught us nothing, the one thing it did teach us is that it's important to be able to segment services into hot and cold sites. And that's really one of the ethoses behind the diagnostic centres, as well as reducing waiting times. Our NICU has been awarded Level 3 baby friendly, and this is a reflection of our ongoing commitment to increase breastfeeding rates and improve care for all patients on our neonatal unit. So that's the trust as a whole. Let me talk a little bit about the reflections of the group model, if I could. So we have established a joint transformation committee, which is now providing collective oversight, assurance and decision making to drive and monitor the delivery of our shared transformation priorities across the group model. There are lots and lots of things around this, and they are around clinical collaboration, for example, and that is really progressing through deep dives at our Joint Transformation Committee. And so far we've had diagnostics, women's health and paediatric teams come and present to us with specific advancements that they are making. it's really exciting to see how you can work together across a bigger footprint. We know across the NHS, and Michael's already referred to what you might do if you have difficulty sleeping, but if you look at the 10-year plan, we know that we are not going to be able to do these things by ourselves. And actually the excitement we can hear when we get those teams together in a room is really, really inspiring. We've also had some really good key collaborations around pharmacy collaboration and around medicines management. Around the corporate areas, we're making strong progress. We've got joint working underway now in governance, in communications, engagement, leadership development training, and around our workforce. We've had 2 board-to-board sessions held in January and July, and these obviously enable us to collaborate at the highest level. We've had a joint Council of Governors meeting in July as well, and that was great to see some real conversations and how we could strengthen our group level accountability and involvement. And we've had cross-organisational staff engagement sessions delivered in March and September. They have 2 different names at the Royal Surrey and Ash St Peters, Team Talk and Let's Talk. I think all that does is confuse me, but the messages are the same, and it's been great to see so many people logging in for that. Group members event, we brought members together for a dedicated group event in April, and we're reinforcing our commitment to openness and a 2-way dialogue. Most importantly, we are really, really pleased to welcome Ruth Colvin-Jackson, who you'll be hearing from later, who is our new Group Executive for Transformation and Digital. It's a newly created role, and it marks the first joint appointment beyond myself. And Ruth will be absolutely pivotal to driving and shaping our transformation. As you know, we've got a single instance of Cerner, so we absolutely need to make sure that we drive our strategic transformation plans and make sure that digital is a real enabler, and really that we are going to look at a culture of continuous improvement. Finally, the group model was showcased at Community Open Days in June and July, giving us the opportunity to demonstrate our progress and strengthen our connections to the public we serve. Okay, if I could just move on to the next slide, please. So I'm just going to give a bit of an overview around the trust strategy, Together We Care, which I'm sure all of you will know much, much better than me. You've been living and breathing this since May 2018. But it's made up of 5 strategic objectives, which you'll see on the slide. And each objective will be presented by the key executive director leading on that area of work. This strategy was developed with a national and local context in mind, and with a mandate for collaboration and partnership working long before we thought about a group model. And we're in the process of refreshing that strategy, which Chris Atto will be talking more about later on. But to be really clear, we want to be fostering strong foundations for strategic opportunities to deliver improved patient care. We really believe that our trust vision of providing an outstanding experience and best outcomes for patients and the team is really what we come to work for every day. We have a mission to ensure that we provide high quality, sustainable healthcare services to the communities we serve. And I would like to just reiterate, one of the things that's come across really, really strongly to me is that Ash St Peters is absolutely grounded in the community it serves. And I think as we look at the 10-year plan and that left shift, we will be moving more and more into our communities to make sure we deliver what is absolutely needed. So the strategy refresh will remain consistent with local policy, with the Surrey Health and Wellbeing Strategy, with the North West Surrey Alliance, and with the 10-year health plan. And we are really clear that actually there's lots of things happening in communities. We no longer have North West Surrey and Guildford and Waverley. We have the west of Surrey. So there is so much to do. It is a really, really exciting time for Ash St Peters, and I really do believe that the group model gives us the best platform to take that forward. I'm now going to hand over to my colleagues to give you an overview on each of these strategic objectives, and we're starting with Jay, new Chief Nursing Officer since this meeting happened last year, and also to Mark, who's our medical director, also new since last year. And just to give apologies for Mark, he has been caught on a train, and so his connection may not be great, either connection, Wi-Fi or British Rail, but he is joining and we're hopefully that he will be able to participate. But Mark, we quite understand the vagaries of the rail system. So I'm going to hand over to them. Thank you.
Yeah, thank you very much, Louise. And of course, this is one of our key objectives, and for that reason, you get 2 execs and not 1. If I could try and squeeze in quite a bit of some of the information, it's really difficult to kind of cover much more than this, so we've selected just a few. And a key one for us is how we've partnered with a charity. And as part of our strategic growth, we've absolutely reached a significant milestone in appointing our first head of charity, Catherine Moore. And some of the work that she's overseeing and the whole team that works within that space is probably symbolized by the partnerships that we've developed with partners in the community. One such partnership is the Bear Hill Golf Club, which provided 80 prostate specific antigen tests to club members as part of the effort to support the aquablation therapy appeal to raise funds for patients who have enlarged prostates. Of course, aquablation is a minimally invasive procedure, which is the direction in which a lot of our medical innovation is going, and provides long-lasting relief for patients and better outcomes as they recover from their procedures. The charity continues to enhance patient experience, and the partnership focuses on staff well-being and innovation across our hospitals. And as part of that focus, we continue to grow the support base that provides the charity operations, increasing its visibility to encourage the local community to donate. And you'll be seeing a lot of that across the hospital sites if you pay attention to some of the decor and the signage up on the walls. And of course, if I just go straight into what we managed to achieve under Healing Arts, an initiative that enabled us to implement an interactive sensory projector in the new children's and young persons outpatient department at Ashford Hospital, which you can see one of the pictures on the slide deck there, which provides a more calming environment for those that may have anxieties to get them to be calm as they prepare for their consultations. One other thing that we managed to do is to work with an exhibition within the community, St. Peter's Untold Stories, a collaboration with Runnymede Borough Council, which owns the Chertsey Museum, where we were able to feature 27 past and present staff members who had a story to tell through their own voices and tell their stories as to what Ashford and St. Peter's and the contribution to the care environment means. And finally, before I hand over to Mark, is to talk about the new phlebotomy service that is now running at the Woking Community Diagnostic Centre that was mentioned earlier on. Phlebotomy services expanded in August, with blood tests now available within the Community Diagnostic Centre at Woking Community Hospital for anyone over 5 years, which means that patients can book an appointment online via SwiftQ at a location that's probably a lot more convenient than many of our hospital options. Can I just hand over now to Mark Rowland? Thank you.
Hi, why am I sitting on a platform in Guildford? And you can probably hear somebody in the background making an announcement. It's been the National Medical Directors meeting in London today, and I've just been caught in terms of timing. So I'm really glad that I've been able to join you, and apologise if there's any background noise. I wanted to highlight how well our neonatal intensive care unit have continued to do this year. They have maintained their position as an outstanding outlier for 2 national audit measures. There's a train going by. I'm so sorry. In the National Neonatal Audit Programme, with outstanding ratings for retinopathy of prematurity screening and a 2-year follow-up assessments for preterm babies less than 30 weeks. The team is so dedicated, and this has been an incredibly validating experience for them, about which they are extremely proud. Our paediatric team have also been pushing the boundaries with a new paediatric diagnostic airway service, which it launched last summer. They have a new vital piece of equipment which is being used to help children with airway, voice and swallowing issues. It's the first piece of equipment of its kind in Surrey Heartlands and is providing huge benefit to children who previously would have been referred to specialist centres outside of Surrey. And I think we're now handing over, if you can hear me, to Jo Fanning, our Chief People Officer.
Thank you, Mark. So hello to those who don't know me. I'm Jo Fanning. I'm the Chief People Officer and just wanted to talk about some of the achievements in relation to our staff over the last year. So you can see on the screen a number of pictures from our very successful Staff Achievement Awards from last year. They were held in October and recognise and celebrate the exceptional efforts of our staff, and in particular focus on our staff values and where staff have gone over and above in terms of the work that they do. We also celebrate some of our long service awards at the ceremony and invite people with long service to come and join in those celebrations as well, and also people who have been awarded the Star of the Month, which I'll come on and talk about. We're very excited. We're literally in the last minute preparations for this year's awards, which are being held next year, and I was lucky enough to be involved in the judging of those and can tell you there's some fantastic nominations and some fantastic stories to be told about all the amazing things our staff do. So really looking forward to that celebration next week. As I said, we also have a Star of the Month award, and there people are able to nominate a member of staff or a team, and that's patients and visitors to the hospitals can also do that, and there's posters around the organisation detailing how to do that. Again, I've been privileged to be able to award some of those Star of the Month nominations to our staff and go and meet them in their work areas and surprise them with those awards, which is a really enriching experience for me to be able to share the words of those nominations, which means so much to people when they hear the kind words that colleagues or visitors have shared in terms of their nominations. So a really positive thing for us to be able to do for our staff. We do also have a number of other ways that we recognise our staff. So Louise mentioned our Pride in Nursing Awards, but we've again just been in the process of judging for our Allied Health Professional Awards as well. And we have a number of days during the year where we celebrate different professions within our organisation and make sure that we recognise the contribution of staff right across the organisation. Our staff survey, so that's an annual staff survey. It's carried out across the NHS, and all the questions are set by the NHS. We were able to rise 8 places to 20th in the country when we compare ourselves against other acute hospitals, which is really positive. And we saw a really big increase in our engagement in terms of the numbers of staff participating in the survey last year. Again, we're just at the stage now of being back into this year's staff survey, and so we're really hoping to be able to achieve that same level of engagement in the staff survey, and are promoting the importance of staff being able to share their thoughts and opinions through that staff survey mechanism. Part of that does shape the work that we do, and one of the areas that we pay particular attention to this year has been on violence and aggression, and we've had a really active campaign and some work led by James Thomas as our executive sponsor for that, to really look at how we can improve the experience of staff who unfortunately sometimes are experiencing violence and aggression within our workplace, both in terms of trying to reduce that, but ensuring that we've got absolutely the right support in place and tackling those experiences. So actually being able to give warnings and use the facilities that we have within our policies to make sure that our staff are really clear that we won't accept violence and aggression towards our staff, and that there are policies in place to support that. We've done quite a lot of work around our learning and development, and that's in terms of our own leadership programme, but also, as Louise said in her opening statement about the work that we're doing jointly with Royal Surrey, and that gives us a real opportunity to both bring an additional learning opportunity for our staff, but give some of our leaders an opportunity to work together and to learn from each other, which is really important in terms of the development of the group. And we're also continuing to roll a really successful career development mentoring programme, where we've had about 50% of our delegates who've attended that have gone on to achieve a promotion within 12 months of completion of that programme. That's been jointly sponsored by our REACH network, and about half of the participants of that programme are from global majority backgrounds. So we're really proud of that programme, and that is a programme that, again, we're looking to share jointly with Royal Surrey, building on the success that we've had within the organisation. Part of that career development programme also involves a number of executives and non-executive mentoring staff that have been on that programme, and that's a really valuable experience, not just for those people on the programme, but also for those of us who are fortunate enough to mentor participants and really hear about some of the experiences of our staff. And lastly, you'll see a photo of our really successful Glee Club pantomime. So the Glee Club are a group of staff who put on a pantomime each year and raise money. And this year we're able to raise £3,700, which has gone into our staff wellbeing charity. And that goes to support staff away days, refurbishment of staff areas, and also other staff health and wellbeing initiatives. So thank you very much, and I'm handing over to James.
Thank you. Good afternoon, everybody. I'm James Thomas. I'm the Chief Operating Officer. So I'm excited to talk about our strategic objective in relation to performance. So last year we had a lot of exciting developments in relation to estates, particularly at Ashford Hospital. We did a lot of redevelopment work on that site, which is continuing to support the full opening of the elective centre later this year. So on the slides, you can see on the slide here, you can see a number of photos of that. So far, well, last year we opened an expanded theatre recovery, new changing rooms in theatres, new offices, a new staff restroom, general store, instrument area, pharmacy room, and work continues last year, or continued through last year, for the 4 new theatres that are open later this year. And you can see the pictures of the staff there, bottom right, and some of the photos at the top, in the middle, and at the left are around some of those new areas. Also exciting at Ashford was ophthalmology. So to make way for the elective centre, theatres and expansion, we moved ophthalmology, and ophthalmology now occupies the whole 2nd floor of the Ashford site. And it's redeveloped into a single co-located area, which will have its own theatres, day surgery recovery. It's got admission and discharge areas, but it's also got a new outpatients area, new treatment areas, and also not just new, but also expanded, so we can see more patients, our expanded injection and laser rooms and new offices. So they're all up in one place in ophthalmology, which is great for them. It's a great new area, and it's great for patients who are all in one space. Another thing that we've done at Ashford in the last year, in the top right, you can see a picture of it. It's our new and relocated paediatric and adolescent outpatient department. We have a new preoperative assessment department relocated on the ground floor. You can see in the bottom left there, that's the new the new phlebotomy and pathology department. And we have new medical records as well there. And we also extended our outpatient department with a new reception as well over at Ashford. So lots of really exciting developments in terms of the physical building and really for the elective centre facilities. On the St Peter's site, we piloted and have run a new ambulatory centre, which treats ambulatory patients from specialties across the hospital, from our same-day emergency care, we call our SDEC, from our emergency department, or from ward areas where patients are discharged and come back to that area for follow-up and treated as outpatients, so don't need to stay in the hospital. So that was an exciting development at St Peter's site. And then you can see at the on the slide, the second photo from the left is the team with the new Da Vinci robot. So that was purchased in the previous financial year. However, in the last financial year was when the surgeons had been fully trained and began to really fully utilise the robot system. So robotic surgery provides a completely new 3D visual way of visualizing or seeing inside of the patient where they're working. Instruments have 360-degree mobility. They can all move. It moves in a way of giving dexterity and precision that we didn't have previously. So the services that we have moved to or are now doing robotic surgery have all done incredibly well. So our Centre for Endometriosis and Minimally Invasive Gynecology Surgery, which we call CMIG, they established a multidisciplinary endometriosis robotic surgery, and they completed 66 complex CMIG cases and a further 200 gynecology robotic services in this year. They also won an award from their Royal College for best presentation last year on their robotic surgical outcomes. Robotic surgery has also improved experience for bariatric patients at the Trust. So with the help of the robot, we can now do laparoscopic surgery on patients where we couldn't do previously because of their BMI. And last year, in the period we're talking about, they became the largest bariatric robotic service in the country. The colorectal department have really been at the heart of robotic surgery. They celebrated completion of 100 robotic major bowel operations in the period over 18 months, significantly improving outcomes for patients. And their data really does show a reduction in length of stay, reduction in readmissions, reduction in complications for these really complex procedures. Also in the last financial year, we designed, established and launched our programme called Waiting Well. This was a unique initiative to St Peter's Hospital. It charted an area that we haven't as an NHS been able to we haven't done much as well as this in the past. This is about keeping patients safe while they're waiting for outpatient procedures or elective surgery. This is about we developed a framework to ensure that safety is really embedded in how we think and approach patients who are waiting for surgery. This was a unique endeavour to us last year. We helped other organisations consider how they would implement a similar programme, and it serves as a real strong foundation to keeping patients safe at all areas of their waits with us at the organisation. So thank you. I'm now handing over to Ruth Colborne, our new Group Director of Transformation and Digital.
Thanks, James, and good evening, everybody. As James said, my name's Ruth. I'm our new Group Director for Transformation Digital, and I've only been here just for a couple of weeks now. And I just wanted to quickly reflect on the fantastic welcome I've received at joining Ashford and St Peters. It really has been wonderful, and it's great to be with you so soon into post to share some time with you this evening. So thank you. What I thought I'd like to do is just sort of touch on a couple of those sort of key achievements that we've taken over the last year or so, and just bring some of those to life a little bit for you. So we've actually done a lot of work and put a lot of investment into our digital infrastructure over the last year, particularly around some of our network improvements to make sure that we're resilient and we improve that sort of access for clinical services into those networks for those working, particularly those more remotely. Patients and visitors will also have noticed the improvement in the free Wi-Fi that's available to you when you're in our hospitals, and that's also enabled some of that Wi-Fi calling for those sort of pockets of low mobile phone reception as well. So hopefully that's making a difference to people. With regard to modernisation, there are a few things that I thought would be helpful to talk to. So we continue to review and implement those sort of technological advancements within our services. We've recently introduced a digital ECG, so our echocardiogram results, directly into our electronic patient record, which allows our clinicians to review those results really easily and also enables us to take some of that paper out of the system for those results. We also have a platform which is a public view, which is a data dashboard that enables staff all across the Trust to view the data and the performance resulting from their areas, and helps us all think about some of those improvements that we can make and little adjustments that we can make to our pathways and our services to improve those data points. We've also had some very practical things in terms of the way some of our teams work. So our occupational health teams and some of our workforce teams have moved to a digital platform where staff can actually book occupational health appointments and physiotherapy appointments online, and managers will also be able to do some of those referrals digitally if required. So all of this work is about enabling some of those time to be freed up for more focus on those clinical tasks. We'll all recognise the focus on AI everywhere we go. That's definitely a topic that we all come across in part of our daily life, and of course we're no stranger to that either. So we're really looking at the increase that we can make around AI for our improved efficiencies, particularly around diagnostics. And we found some really great work that we can do there around the routine review of chest X-rays, to identify anomalies much more consistently. So a real live example of how we're starting to deploy some of those sort of really new technologies. We've also got another piece, which is a system called Dora, which has freed up some staff within our ophthalmology services. So Dora is a system where we can call patients after discharge from our services and ask questions. And that's really helps us think about how we provide that aftercare to patients after some of those hospital visits. We're piloting use of some ambient voice technologies in our outpatient departments where notes are taken, again, freeing up the clinician's time to concentrate on the consultation and a focus on the patient rather than taking those notes in clinic. And we're now looking at how we can use AI to also think about scheduling appointments, particularly thinking about children or paediatric patients, where we can think about booking appointments outside school times and more appropriate times, again, to sort of enable patients to access at a time most appropriate for them and keep our missed appointments as low as possible. We also have a real focus on moving to sort of be much more paperless across the board. So we have a platform called MyCare. And this is where patients for selected outpatient appointments can actually opt to go paperless and receive appointment letters through the MyCare platform instead of receiving paper letters in the post. And further functionality is being explored in this area now, particularly thinking about being able to rearrange appointments, view tests online, and be able to contact clinical teams. So those are all functionalities that we're looking forward to bringing online in the next little period. So just a little taster, and as I say, a couple of weeks in, just some initial reflections that have been great to think about with the team in terms of achievements this last year. So now, if it's okay, I'm going to hand over to Chris Atto, who's our Interim Director of Strategy. Thank you.
Thank you so much, Ruth. Hi, everyone. Lovely to see you. Good evening. I'm Chris Atto. I'm our Interim Director of Strategy. I'm also Substantive Director of Strategy at Royal Surrey, and I've been in the role since the start of June, covering for Tom Smurden, who is currently on secondment to run our community service provider, Central Surrey Health. So it's a pleasure to join. I should also preface, as Ruth did, that lots of the work and exciting things I'm going to talk about predate me and were done by other people much better placed and better suited. So certainly want to thank everyone who's enabled me to provide some highlights. On our collaborate objective, as everyone will appreciate, working in partnership, working with the other people who are part of our health and social care system is a critical part of what any NHS organisation does, and that is a means by which for us to thrive as an organisation, and for our patients and our local populations to be able to thrive individually and collectively. So a really important area that I'm really pleased to talk about. To start with some highlights, our Woking Community Diagnostic Centre, which I hope maybe even some people on this call have been beneficiaries of, is a great example of local collaboration. The new centre is part of the wider community diagnostic programme across Surrey Heartlands and nationally, and we've worked really closely with our community service provider, Central Surrey Health. We've worked really closely with our GP Federation, North West Surrey Integrated Care Services, or NICS for short, Alliance Medical, and various other suppliers and providers who are all now part of us operating out of that building of Woking Community Hospital. The development's also been very lucky to be supported by Rotary Clubs of Woking, the League of Friends for Woking Community Hospital, and our very own Ashford and St Peter's charity, for which we are extremely grateful and very pleased to be putting the local generosity to good work by making a better experience and better care for the people who need to access our services. The centre will, in the future, prevent the need for 30,000 hospital visits that would normally be going outside of Woking each year, as well as providing a vibrant and modern health facility for residents to be accessing. We know that's a priority for patients. It's also a massive priority for staff who want their patients to have a great experience in a great environment as well. I'm very sorry to have missed this. Rishi Sunak had a visit to Woking Community Hospital while he was Prime Minister at the time. He came down with the Woking MP, Jonathan Lord, to meet with staff and learn more about how we run our services there. Took time to speak to the staff, meet the clinical team, including one of our radiographers and a patient who was accessing the service as well. So a lovely highlight. Another key principle or key area of work for our Collaborate objective is working closely with our Trust Provider Collaborative. So that's a group across Surrey Heartlands of NHS trusts who work more closely together. So that's ourselves, Royal Surrey, Surrey and Sussex Health, and also our mental health provider, Surrey and Borders Partnership NHS Trust. There are a series of shared strategic objectives as part of that collaboration, including some key clinical areas, with a real focus being how do we transform our clinical services at scale as a group. The idea is working collaboratively at scale will help us to provide better access to patients, better outcomes and better experience, as well as doing things in a more joined up and innovative and effective way as a system. So potentially creating savings and efficiencies in those environments as well. I am responsible for one programme relating to the delivery of systemic anti-cancer therapy. And that's an area that I'm really proud that we've had some progress in being able to look at exactly where patients are accessing their chemotherapy support and what that means for travel times, and being able to work out if there's a better way for us to organise those services so that people are receiving care closer to home and quicker, in a better way for our services and staff to be able to meet the growing demand in that area. And there are many other examples of excellent work like that as well. An important one to highlight that I feels a bit like I've maybe stolen from Ruth's update is work on virtual wards. So this is a way of getting patients home sooner to recover in an environment where they're safer, they're more accustomed to their environment, and there is evidence that people recover quicker under those circumstances, but also to make sure that they're getting the care they need safely and not being exposed to a hospital environment if they don't need to be. We've been developing those virtual wards, particularly for patients in our frailty services, our colorectal services, and paediatrics as well. And again, doing that in really close partnership with our partners in the system and in our local communities. We know this is a really important service that is going to grow in future as well. So it's a great place for us to be working and dedicating energy and getting to know best how to do this across the system as well as locally. So clinical strategy is the next thing I would like to share with everyone. 2024 saw us launch a new 5-year clinical strategy, which is really exciting, encapsulates a huge amount of work from people within the trust and engagement with people in the trust and our local partners and stakeholders. So the real core focus of that is to make sure that in collaboration with other people, we're able to make sure our population has access to the highest quality services that we can possibly provide. And we want to make sure that the way we're providing those is thought about, is purposeful, and is organised in the best way possible, even taking into account some of the limitations and restrictions of the environment we're working in. We know that we need to work together to make sure that people get the right health and care provision at the right time and in the right place, and even working on that prevention agenda to make sure that people are supported to manage their ill health outside of hospital or outside of hospital services, and also to promote good health and build better health and well-being in those groups as well. And what we've really tried to do is make a strategy that is evidence-based, plays to the current strengths of the organisation, and tries to take a robust and systematic approach to the areas we want to focus energy. So it gives us clarity of thought and clarity of decision making when we do have decisions to make. I'd love to mention more about our group model, which we've already heard a little bit about, but in particular, there's some really important work that relates to both our Collaborate objective, but also our overall approach to strategy. So the vision for our group model is to make sure that clinically led improvement allows us to share best practice and standardise outcomes for our patients to make sure they're getting the best possible care and in a timely way as well. This aims to help us cope with challenges that we're collectively facing. So growing demand, the need to transform the way we work to be fit for the future around innovation, around being financially sustainable, and delivering a more neighbourhood health approach to care out in the communities, a more preventative angle, and working more in collaboration with other local system partners. There are also more systematic ways of working together that are really important for that group. So the overlap of our populations to make sure that we're moving patients to the right places for them. We're already part of some of the initiatives I've mentioned earlier around the Trust Provider Collaborative, and there are non-clinical and corporate angles to that as well. So one area of joint working is around our electronic patient record and our patient portal, and making sure that we're able to give patients as seamless as possible an experience when they're coming into our organisation, and that our staff are able to access what they need in a timely way as well. And the last bit for me is just to mention some of the work that Louise signposted to earlier, a really exciting opportunity to refresh our trust strategy. So the 5 strategic objectives that we've based the last 20 minutes or so around are really important. We're taking the opportunity to refresh those, have a look at if they are the right strategic objectives, how we might reshape them for a modern world, looking ahead to the 10-year plan and looking ahead to the coming years. And we've kickstarted that work with some engagement work internally and have some more engagement to follow externally as well. So definitely one to keep your eye out for. We have an engagement session planned for the middle of November, and we have a date later this week, I think Friday, of launching a public survey to gather people's views as well. So watch out for more on that. And it's now my pleasure to hand over to Hannah Hamilton, our Chief Financial Officer.
Thanks very much, Chris. Good evening, everyone. My name's Hannah Hamilton. I'm Chief Finance Officer, and I'm pleased to be able to talk to you about how we spent our money last year. So last financial year, we planned to break even, but throughout the year faced cost pressures that we were unable to cover, which did mean that we moved our forecast during the year. We did deliver that forecast, which was an 11.3 million deficit. This was disappointing, but was due to a number of factors. We had shortfalls in our cost improvement plan of 5.7 million, and that was against a stretching plan of 25.6 million. We had £1 million of income that we expected to receive but didn't, and then 4.6 million of other cost pressures. That included things like additional mental health nursing costs, transport costs, and drugs and devices costs. So all of that led to us having a deficit last year. Our income compared to the year before in 23-24 grew by 11%, which was just short of 50 million, but our costs grew by 11.7%. So that slightly higher cost growth than income. Now for this year, for 25-26, we've set a break-even plan again, and with a stretching cost improvement programme this year of £33 million. So at present though, it is positive to report that we're on plan. In the bottom left graph, the earnings before interest, depreciation, tax and amortisation, that you can see that has been reducing over the last 3 years, but the plan for 25-26 is for it to increase up to 4.6%. So it'll see a big increase up if we can deliver our plan. So year to date, we're at 2.3%. So it's already improved. Next slide, thanks. So this slide is around income. So we received just shy of 493 million in income. And as I said, that was nearly 50 million pounds more than the year before. The majority of this comes from our commissioners, so both NHS England, Surrey Heartlands ICB, and other ICBs around the southeast and the rest of the country. But we also got 14.6 million education and training income and 19 million from other income streams. Now those include things like research and development, private patients, car parking, catering and the creche. All of these income streams are absolutely critical to enable us to be financially sustainable. Next slide, please. We'll show where we spent our money. So we spent 512 million last year on operating costs. Now you can see that a huge proportion of this, 2/3 is on staffing, so 335 million pounds. And then clinical supplies and drugs make up 72 million pounds of our costs. So those 3 areas are a huge proportion. Every year we have a challenging SIP plan, and we need to look forensically at all of these areas of expenditure where we can work efficiently and effectively to really make the best of the money that we receive. Now our other area of spend is capital, which is on the next slide. So on capital, we spent 20.8 million in 24-25. The majority of our spend was on the elective centre, which you've heard about, and the Woking Community Diagnostic Centre, but we also spent money on electrical resilience, maintenance, equipment replacement and IT. Now the budget for this year is 21.7 million, so only slightly more than last year. We're spending just over 2 million on the Macmillan Cancer Centre, which will open in 2026. And 6 million on theatre refurbishments, the emergency department and neurology procedure rooms. Now, all of these have external funding, which is positive. And from our internal capital budget, we're spending nearly 6 million on equipment, nearly 2 million on IT and digital, and the balance is all on backlog maintenance, refurbishments and electrical resilience. So I'm going to hand over to Alpha now to talk about bariatric surgery.
Thank you very much, Hannah. And also thank you very much, governors and everyone, for giving us our the bariatric department opportunity to present our unit, our work and our success this evening to you all. My name is Apiwat Longsombun, locum consultant, upper GI and bariatric surgeon. We're also joined today by Mr. Rukala, consultant surgeon and deputy medical director, Mr. Ratan Singham, our specialty leads, and also Jess Vaughan, our bariatric specialist nurse. Also, our team have got 4 Ashton St. Peter's Hospital consultants and 3 visiting consultants from Wrexham Park, Epsom St. Heliers and also Medway Maritime, with 4 bariatric nurses. So I would like you to look at our journey of our unit. Next slide, please. So the journey actually started in 2008 when Mr. Horner started the very first gastric band insertion in our trust. In 2010, Mr. Humadi started bypasses surgery at St. George's Hospital, and only in 2012, Mr. Humadi and Mr. Rukala started our bypasses at St. Peter's Hospital under the wing of St. George's, and then we became independent in 2014. In a 6-year period from 2014 to 2020, Ashton St. Peter's has become the 3rd largest bariatric unit in the UK. And the unit has expanded further with the visiting consultant models that in 2021. And by 2023, we have become the largest unit in the UK. And with the introduction of the robotic surgery and Da Vinci in the hospital, we have become a robotic bariatric centre. As James Thomas said, we actually has become the largest robotic bariatric centre in the UK. So next slide, please. One of our significant achievement of the trust is the visiting surgeon models. Can you go to next slide, please? These allows us to expand the unit to larger area, and you can see that our catchment area is limited in the yellow highlighted area, but with our 3 surgeons, we expanded to Frimley and Wrexham Park and Epsom St. Heliers and Medway Maritime, and also we have got a patient from Frimley, Guildford, and surrounding area as well. Can you go to next slide, please? This is from the National Bariatric Surgery Registry. This slide just to highlight the amount of work that we perform between 2019 and 2023 across both sites by all surgeons. We can go to next slide, please. Looking into our annual figures from last year, as James previously mentioned, that we have become the largest bariatric unit in the country, and we have done nearly 25% of our work by robotic work. And also we have done overall of nearly 600 cases per year. If you compare to the rest of the country on the NHS, the country does about 4,500 cases, and we essentially do about 12.5% of all. Can we go to next slide, please? What it means is not about expanding the unit, but allowing centralizing the unit to improve the care for our patients, training our future nurses and surgeons to ensure that our patients receive world-class care in bariatric surgery, and that the patient safety is our priority. That is the whole aim of expanding our unit. I would like you to have a look at our service overview, and we can see now that our referral is about 95 referrals per week. And in 6 months period, we have received 1,600, roughly 1,700 referrals that we have to get through. The patient will need to go to be triaged in our clinic, and we only have 3 clinics per week, and that allows us to see about 60 patients for triaging. Then these patients will have to go to one-stop clinic where the patient will be seen by the great work from our psychologists, bariatric nurses, anesthetists, and also the surgeon. And we only have 3 clinics per week, and that will see about 18 patients per week. When it comes to operating, we operate about 6 lists per week, and that's roughly about 18 patients operated per week. We can actually see that there's a big bottleneck here, and the patients' waiting list has gone up. So with the great teamwork of our nurses, surgeons, the administrative team, anesthetists, and also the trust, we have implemented many things to improve our service. We have introduced advice and guidance to allow surgeons and our clinical fellows to screen order unnecessary referral and to see whether the patient who has been referred to us genuinely needs to be seen. Then we have done what we call Super Sundays. These Super Sundays allowed us to try a great amount of patients. We had seen about 150 patients per week, and we had piloting, and we had done about 3 great Sundays, Super Sundays so far, and we are aim to continue more. We have done more of the one-stop clinic by the WLI, and also we have got more lists for the bariatric list, and we are now introducing what we call hit lists, where there will be more patients operated. But these cannot happen at all without great work from our great team. Can you go to next slide, please? So just an overall update for our service. So we had a very successful bariatric hit list where we operated a great amount of high amount of patients in one list, and we finished by 2 o'clock in the afternoon. And we aim to have a Super Sunday triage clinic by a team of our 4 nurses, and also we have trial to do consulting bariatric triage clinic where the patient will be seen by the consultant surgeons on their very first visit to reduce the further appointments throughout along their journey. These will reduce the number of patients to one-stop clinic significantly in the future. At the moment, we are working very hard to get help from phlebotomists so we can run it on regular basis. From June 2025, with the introduction of Mounjaro, which is a new GLP-1 injection to our service, in addition to previous medical management of the morbidly obese patient, we are currently working on electronic prescription, which has been outsourced to the home care service, which will be in action very soon. So the patient can get access to the medical prescription and they do not need to come to collect them on site. We also start to pilot our day case bariatric procedures where the patient can have the operation done on the day, and they can go home as a day case. At the current setup, they normally spend 1 night stay in the hospital, and once this up and running, we will be able to provide a smooth service to the patient without having to cancel the patient when we are under a lot of pressure with a bed situation. And these patients will be carefully selected initially, and and the great amount of work has been put in by a lot of people in our team, and is ready to go on trial. Apart from all the clinical work that we do, our unit is also very keen in performing audits and also conducting research. And we have found that robotic surgeries is not just another gadgets that we can use to operate, but we find that robotic surgery actually improve our service and also improve the care of the patient. What we used to be having is laparoscopy, having difficulty to operate on a very high BMI or overly overweight patient, and many of the patients had to get abandoned from the surgery on the day because it's not suitable to perform the surgery. Robotic work allowed us to achieve the surgery, and many patients that have been abandoned in the past allowed to then had a successful operation done by robot quite recently, and we continue to work on this, and we will continue to do audits and research on this to see whether there will be true benefit from the robotic work. As I mentioned previously, that we have got lots of challenges, but as a team, we work really hard to overcome those challenges, and we try to provide a better service to our patient. Go to next slide, please. So our future plan is to really try to expand the robotic work, and we will receive one more Da Vinci in a very near future, and these will allow us to have a better research on whether the patient will achieve the better weight loss from the robotic work compared to laparoscopic work. And we aim to do more complex and more revisional surgery that many other trusts are not performing at the moment. And we will continue our great work with a successful hit list, and also we will try to manage our waiting list to the minimum by creating more clinics. And we will also try to get our day case bariatric procedures done up and running very soon, so we can ensure that during the winter period we do not have to cancel our patients. And that's it for me. Thank you very much.
Many thanks, Alpha. Well, I think that was a fantastic presentation. You mentioned great work from a great team, and I think that was great presentations from a great team there. So yeah, at this point in time, actually open to any sort of questions. Do want to thank some before we do go on to questions. So Ko, thanks very much for actually orchestrating and choreographing those presentations there. That was very, very helpful, and allows us to get ahead of time. So we've got plenty of time for questions. If you've got questions, I'm just going to take a look in the chat, see if there's anything that's been opening there has been going along. Can't see any questions in there. So if I could ask you to raise your virtual hand if you've got a question to ask, and I'm going to rely on my colleagues as well to prompt me if there is anything. I know we covered a lot of ground there.
I think Julie has her hand up, John.
Right, okay, Julie. Julie? I think, yeah, fantastic.
Yes. Hello. Sorry, I've been having a few IT problems, and
no, don't worry.
We
know what it's like, Julie.
So first of all, so I'm Julie Callion. First of all, just to say big congratulations to everybody who've done their presentations tonight. It is truly inspiring what we have been hearing. So I just want to say thank you to everybody for your presentations, but also the hard work that everybody is putting in. And I have personally, over the last few months, been at the receiving end of robotic upper GI surgery, and it was great. So thank you. So my question is,
So what plans are there to ensure that the patient voice is heard, effective and enhanced in the light of the abolition of independent patient voice organisations? And I'm particularly thinking about the hard to reach groups who would not necessarily complete the friends and family test or make complaints or give compliments.
I think it's a really good question, Julie, and it's actually one thing that has been discussed quite extensively at board, because I think that we are obviously very interested in making sure that we do get to those hard to reach cohorts of patients. And I think also with the changes that are being proposed, particularly when you've got patient advocates, it is something that we need to deal with. And issues have been raised, obviously, with the ICB and NHSE as well, in terms of how do we make sure that we get those patients' views heard loud and clear. But I don't know, Louise, do you want to comment on this?
Yeah, yes, thank you very much, and thank you, Julie. Sorry, just because the government is making this this suggestion doesn't mean that we're going to follow it. So we have a really active Maternity Voices partnership, and I think that's a really, really good way of listening to what people think. We still have patient panels, and Chris obviously is doing all the work on our strategy. We are absolutely going to take patients' opinions into that. It is all very well us sitting here in Chertsey and thinking we know what's best for patients, but we absolutely don't unless we hear the patient's voice. So I think you will get an absolute commitment from this executive team that we are going to be trying to pull in everything we can about listening to what it really means for patients. And I can particularly see Ruth nodding. And, you know, once again, we can design digital processes, but if they don't work for you, then they're absolutely useless. So doesn't mean we're going to have to follow what the government tells us to do in this case.
And Julie, it was good to actually get your patient feedback before, so thank you very much for sharing that with us.
Thank you.
Really appreciate it. It's nice to say thank you, isn't it? So
absolutely.
Right, I think there is another hand up. I can't see it at the moment. So I've got so many tiles open on my machine.
Yeah, my name's Alan Ratcliffe. Can you hear me?
We can, yes.
Yes, I'm here with my wife Judith in Addleston Weybridge. And it might be something for Ruth. And there's been so much publicity, adverse publicity, about the problems created by hackers and the devastation that this would cause if people's confidential records were accessed or clinicians were trying to access data which suddenly disappeared. What is the strategy for trying to stay out of the clutches of the hackers and the devastation that they've caused in the commercial world with Marks and Spencer and JLR Land Rover, and it's the emotional costs and that would be devastating for all concerned. So does the NHS have some sort of national strategy for dealing with this, or is it left to individual trusts?
Alan, I think it's a very good question, and I think we're all very aware of what happened with phlebotomy services in terms of the attack, which was a supply chain attack. But maybe I can turn to Ruth in terms of maybe talking about cyber essentials and cyber accreditation.
Yeah,
I'm cognizant that you're still only 2 or 3 weeks in, Ruth. So if you want me to chip in, then I will do.
Thank you, John. That's very kind. And hi, Alan, and nice to see you, Judith. Thank you for joining. Yeah, I mean, a great question. And just this morning, there was more news, wasn't there, about Land Rover and the progress they're making with their way out of that situation. So yeah, of course, it's something that we take really seriously. There are lots of national focus on this across all public sector bodies and government departments, and health is no different to that. So we have that as a core part of our attention. We also have, as you alluded to, Alan, appropriately, we have those local strategies and those local deployment plans within all of our organisations, and we continually review that as part of our governance and as part of our assurance process. We have committees and appropriate structures under which we take that assurance in through to our board. So in short answer to your question, yes, we take it very seriously. It's consistently under review. It is a topic that we are obviously very focused on, as you mentioned, with all the focus, and it is nationally supported as well as having local deployment. So I hope that helps.
Yeah, because it comes down to staff taking practical steps to stop this happening. Oh dear. Oh,
Alan, can you still hear me?
Sorry, I think I accidentally. Can you hear me?
Yes, we can.
Yes, I can't say we accidentally pressed the wrong button on the iPad. So it does. Yes, thanks for the answer. It does come down to individual staff knowing their duties and thorough discipline in carrying out what's expected of them.
No, absolutely.
The data.
Yeah, all the technical issues that you know in terms of backups far more than we do, and the reality.
Yeah, and I can assure you.
Yeah.
Alan, I can assure you that as a board, we take this extremely seriously. So, and as you'd expect, we actually do sort of random testing in terms of whether people would be prone to, clicking on things like phishing attacks, etc., etc. So those things are extremely important because we know that there are these actors out there, be they organised crime or even states now. So it is extremely important to all of us.
Good. Thank you very much.
Thank you. Richard?
Hi, sorry. I think you missed me. I'm Councillor Matt Buck, appointed governor. And I was on the board in 2023 and back again on 2025. And I can see the lot of good work that have been happening during the last 2 years. I would like to take this opportunity to congratulate everyone for their hard work, and especially to move, especially when you talk about the maternity was a big issue. And today we are so pleased to see the progress, and congratulations to the team. And going forward, I think there's still much more to do. And what do you see as the most significant challenges facing the Ashford St. Peter's and Ashford Hospital, whether regarding performance or operational or staff financial? What do you think it will be the most challenging factors that you should consider for more performance in the next 4 or 5 years?
Don't know, Louise, do you want to come back on that?
Yes, of course. So I think there are 3 areas that we have to consider for anything we look to do and improve over the next few years. And that has to be safety, quality, and then our workforce, actually 4 things, and the money. So things we need to take forward, and you've listened to the presentation about bariatric surgery. So I think robotics is a really, really important part of how we take forward what we do. But being mindful that not everything is as exciting and cutting edge as a robot. We've still got really big areas we need to improve on around general medicine. We would like absolutely our services to be rated as outstanding across Ashford St. Peter's. The safety of what we do is really important. I think we have got a big piece of work we need to do around affecting some of the culture within the organisation to make sure that we are really open when things don't go as they should, and that we really learn from those. I think our performance, we have areas of great performance, we have areas that we are struggling with, along with just about every other trust in the country. We have long waits in ED, and we have people who are waiting far too long for surgery. But I think those will be addressed through some of the innovation and quality areas that we really need to be moving on. Workforce, we need to make sure that we try and keep our workforce happy. I think there's much less movement around at the moment. I think people are much more worried about jobs, but just because people don't necessarily have other things to go to doesn't mean you shouldn't focus on making your staff survey and your patients the best experience they can. And we know the best thing we can do for staff safety and for patient safety and quality is to have happy staff who want to come to work. And finally, obviously, we need to concentrate on the money. I mean, Hannah's given you an overview of that. The money is going to get tighter, and we are going to have to really focus on what absolutely only Ashford St Peters can do. Are the things that we should be sending back to GPs, to other parts of community services, because we need to be really clear that what we do has got to be value adding. So that's a long list. I hope that helps a bit.
No, thank you very much. And also just one point, I'd like to add, as regards to the performance, because what we can see, for example, you mentioned about A&E wait. This has not been better. It's getting worse over the last 5 years. And how are you going to cope? Because now we're getting into winter pressure very soon, and there will be more, because being a counsellor, I'm in contact with people who use the service and always hear good things and bad things. But during this period, people always complain about the wait or the waiting list, the operation postponed. I know you're going through some doctors' strikes and all that has affected. But this is how do we control this situation so that it doesn't affect the service user to that point? So do you have a specific plan? For example, the A&E. This is one of the most heard topic out of all my constituents. So is there something that you have in place? You mentioned technology, but I don't know how much technology can help in that.
Well, I'm happy to just give an overview, and then probably James could give you a better answer to that, who's our Chief Operating Officer. So you're absolutely right. Too many people are coming to ED. So there are various things that are within the 10-year plan that we're trying to do about that. Can we keep people at home? Can we provide community services in a different way? As you know, we have an urgent treatment centre on site. How do we? I think the whole piece is around making sure people go to the right place, and I'm sure you're seeing all the TV and radio about making sure you perhaps start with a pharmacist first, and there being extended powers for pharmacists. But we do have a very detailed winter plan that we have submitted to region. And James, don't know if you want to just say a bit more about that.
Yeah, sure. Thank you, Louise. I think Louise is right. The challenge we have in terms of urgent care is multifaceted. It's in terms of attendances, it's in terms of complexity and presentation. But there are things that we're doing. And in terms of the technology question, there are things we're doing around virtual wards, which is where we can look after patients at home, patients with wearable devices that can record patients' conditions and report back. So there are things that we can use on the technology front in the urgent care space. Our winter plan is comprehensive. It covers what we're trying to do around surge. We've got 7-day services. So, for example, last weekend we went live with our 7-day Frauti service, which is a specialist service for the patients who are the most frail in out through our ED. That's running 7 days a week. We've had huge success with a 5-day service, and so that's on 7 days a week last week. We're working with partners to make sure that we are better at turning patients around in ED and supporting people at home quicker. But there's a whole variety of things, including looking after our workforce and supporting our flu vaccination program within our organisation so that our own staff we aren't short of our own staff. So there's a whole range of things, one to do with technology, but around what we're doing through the winter. It's an ongoing problem in terms of our performance. We are challenged. When we look around, we are absolutely in the average place for urgent care in England. So we are experiencing the same level of challenge, and we are at least as well as everyone else in terms of how we're performing. It's not where we want to be. We want to be better. But at the moment, considering that context is useful context to consider where we are and how we're delivering against the current challenge for urgent care.
Thank you. As a council, is there anything we can do to help you to overcome your challenge? Is there anything you expect from us? How can you support you? Because we want the best experience for the service user.
Matt, I think one of the things is that accident and emergency is called accident emergency for a very good reason. And I think if we can actually say to people that we are serving, the community that we do serve, is this really an accident? Is it an emergency? We certainly had presentations recently from like the emergency community response team that we have, who are now taking people out of the ambulance stack before ambulances are actually dispatched. So there you've got paramedics actually going out to deal with people potentially on site rather than them ever even coming to ED, because I mean, no one really wants to be in an emergency department. I do know that. I really do appreciate that. I go in there a lot. So yes, it's not the place that you want to be.
Thank you.
No problems. Right. Okay. So I think next is off the tracks is Richard Middleton.
Thank you, John. And again, I thought there was an awful lot of positives, very encouraging in terms of everything that's going on in Ashford and St Peters. So as a volunteer, I mean, I find that extremely extremely good news. Just in terms of the point on patient voice, I mean, one of the things I would say is that working on patient feedback, I believe we've doubled response rates in the last 12 months, and we're looking to achieve a further step change and actually looking at lots of different sort of ways that we can get sort of make it easier for patients to give feedback, and obviously then actually improve the analysis of that feedback, and particularly around the verbatim comments. So I think there is quite still there's a lot of work being done on that particular area. In terms of my question, so as I say, lots of great things happening. Really impressed with a lot of the innovation. It was great news on the midwifery grading as well. I'm conscious that public league tables have come in, and I think it's fair to say we're sort of upper mid-table. I think it's probably fair to say on that, and then of course you've also got the tiering system as well in terms of emergency care, diagnostics, etc. And I just wondered if perhaps it's one for Louise or the Chief Operating Officer even, whether all the impacts that we've seen, all the good news that we've seen, whether those are likely to lift us appreciably in the league tables, and indeed how we as a trust benchmark ourselves against other similar sized and graded trusts.
Richard, I think it's a great question, because I think one of the things that we're very conscious of is with publication of league tables that it could potentially influence people's choice of where they would want to go. So I think that we're very, very conscious of that, but maybe I can hand over to Louise for some more nuance on that.
Yeah, thanks, Richard. So a couple of things there, I think, really. As you know, there are two, as you've mentioned very clearly, two separate pieces here, segmentation and tiering. So segmentation, we are in segment 3. And the reason we're in segment 3 is because we took some provider support funding at the beginning of the year. If they told us that would affect where we would go in segmentation, we might have thought again about that, but segmentation hadn't even been invented when we took the money. So because of that, you can't be any higher than segment 3. And we are 51 in segment 3. We're 51st in that league table. If we hadn't taken that money, we would be in segment 2. They've been very clear about that. So that would move us, I'm sure quite a way up. I think that we are looking very carefully at all the metrics within that segmentation piece. I think they started off with about 300. They ended up with 30. One of those has already changed. And we are expecting to see more metrics coming into that. So I think it's a bit of a wait and see how we can position ourselves to make sure that we try and move forward and get into as good a place as we can. And in fact, Ruth, whose job prior to this was working on this, might be able to give you a bit more insight. But the other thing really is about the tiering piece. We know that we're off track on a couple of areas. We've put in plans which I am told are being held as some of the best that they've seen across the whole of the system. So I take great faith in that. If we put in a plan that we'd already got a plan how we're going to make things better. We put that plan in, they said, yes, thanks, that's a good plan. So, I'm not really sure quite what is added by, if they told us to write a different plan, then I would get it, but they haven't. I think we're really cognizant of where we are. One of the reasons that Ashford St Peters is struggling with some of the long waiters is because we have behaved in the correct way as we should within the system and taken some long waiters from other trusts, including the Royal Surrey. So although Region very understanding that was the right thing to do for the system, there is a piece there which really says those long waiters should have gone back to the trust that sent them in the first place. But we work with the system we have. But it might be worthwhile, Ruth, I don't know if there's anything you just want to add, because you have much more intimate knowledge of this than me.
Yeah, thank you. And great question, Richard. And so I think this was, if we take a step back, the part of the work was all about the sort of transparency agenda that the government wanted to put in place in terms of helping both the public and organisations understand relative performance across a number of domains. But as Louise said, the sort of process and the metrics that have been selected have moved quite a lot, which has sort of moved that emphasis around a little bit. So it's been quite difficult in organisations to sort of respond to that in the immediate term. But your point about how thoughtful can we be about the impact of our innovations, particularly as we take a step forward into the next period of time, and really tying those into some of those pieces that we know really matter to patients and really matter to our population around some of those core metrics and some of those core sustainability pieces, I think that's a really good point to make sure we're focusing our time, attention and resources into those areas that we know the public care about particularly, and would offer us the opportunity to have that sort of sustainable position, as Louise has already mentioned. So I don't know if that's helpful, Richard, but a little bit of context, but I think that impact piece is particularly important for us to reflect on. So thank you.
Thank you very much. I think I was just going to say, Louise, just as a quick counter question, obviously the money that you were talking about that obviously affected the tiering, and I don't want to get too hung up on this really, but I think ultimately a highly tiered trust is not only good for the patients, but I think it's excellent for staff morale as well, because you kind of know you're working in a really great team, so the higher the better really. But in terms of, is that an annual measure? I mean, I appreciate we're talking about something that's probably a fluid measure at the moment in terms of the metrics. I mean, that's something that's come across to me from this brief conversation. But is that something that works its way through in 12 months as far as we know, or is that that?
It won't be available next year. So then they might put us into a different segmentation because of the money. So it's all swings and roundabouts. But at the time, it seemed like the right thing to do. And both Royal Surrey and Ashford St Peters took the money.
Okay, thank you very much.
Thanks for your question. So I'm going to move on to David now, and then I'll actually deal with some of the things in the.
John, I don't know if Hannah just had her hand up. I don't know if she wanted to come back.
Hannah, did you want to come back on that?
Sorry.
Yes, thanks. I just wanted to add, Richard. So for the rest of this year, because we took the money, we won't be able to go above a 3. So I think they will I thought every quarter they are likely to redo the metrics, because ideally you would of course move up the table, wouldn't you? So of course we'll be working on, and the ideal would be that we do move up. So unfortunately though, no matter what we do, we will be in that 3, but nevertheless we will do what we can to move up all the metrics, with the ideal that next year we won't take any deficit support funding, which would enable us to then be at a sort of a proper reflective position. But we're starting the planning process now, and they're waiting the financial framework details. That's all being worked through. So it's all a little bit unknown at the moment, but that's certainly our hope and ambition for next year.
Thank you.
Yeah, I think it's nice to know the rules of the game, isn't it, before you play it really sometimes. Yeah. So the retrospect. David, thanks, Hannah.
Yes, I just want to say first of all that thank you for such an extensive and positive survey this evening. My question is, I understand from Guy's and St Thomas's, there is a link with St Ashford St Peter's on paediatric congenital heart disease. So I'm wondering if there has been any advance in improving interoperability between Cerner and Epic software. My interest is personal in that my consultant is at Royal Brompton, and there is no way that my care and my chart can communicate with each other.
David, I think that is an absolutely brilliant question around interoperability, because it's certainly, the IT is certainly one of my backgrounds as well, and well, we obviously have islands of technology within the NHS. Unfortunately, it is what it is. As you're probably aware, we've only got two really major systems, and you've mentioned them there in terms of Epic and Cerner. There are others, of course, and their ability to actually then see you as an individual and consolidate your record is extremely important. So I don't know, should I ask Ruth at this point in time to see whether she wants to add any more to that? Interoperability is obviously a key thing. It really, really is.
Thank you, John.
Ruth's still
Thank
smiling,
you.
so I presume that you want to say something.
No, I don't, but I'm still smiling. Thank you, David. Great question. And as you say, John, the piece around interoperability, be that between those two particular organisations or any others, to ensure that, as John said, you as an individual are viewed in that way, in the sort of digital note space, is particularly important. I don't know the answer to your particular question, but it's a great one. So I shall go and pick it up, and if you like, I will connect back with you outside if that's helpful to follow up, if that's useful. But thank you for the question. That's really helpful.
I would appreciate that. Thank you. Yes.
And David, your comment is not lost on me.
As well.
We should be the most, customer-centric organisation everywhere, shouldn't we? And unfortunately, maybe we're not. You probably get better customer-centric stuff from some of your banking relationships, but that's just the way that it is. But hopefully we can change that. It's certainly something that is obviously fully understood, but needs further work as far as interoperability is concerned. Is that okay? We will come back to you. I've got a couple of items here that are actually in the chat, and JJ, I don't know if you actually want to raise this thing yourself or whether you just want me to say it. So I don't know if JJ, if you're there.
Yes, I'm here.
Right. Okay. So I think you raised a couple of things. One was actually in relation to the unfortunate experience of having to go to A&E, but then you sort of you enlarged on that comment, which is actually very, very good. But then also that you've talked about SABP as well. So yeah, do you want to talk? And Silver, do you want to ask your questions?
Yes. With regards to so I don't usually use the acronyms, but for example, I know people who have had consultations, and the consultations they've been dictated, but they only get typed up a month later, and then the letters go out to the patients, and that's a delay. And because we're into digital tech, we're supposed to be going more tech savvy, don't you have a system in place where you can directly upload those dictations straight onto a online system so that they can be issued out automatically to the patients?
James, do you want to come back on that one?
Yes, thank you. That's a really helpful question. We have had problems. So there are a couple of answers to this. One is we have had a challenge with a recent software upgrade around the whole digital dictation platform the organisation uses, which has inadvertently caused delays. So that's part of the issue. But you're absolutely right that digital is the way forward. So there are two things that we're doing at the moment. One is there's a trial in some areas of the hospital of dictating straight to text. So there's no need for any of the stuff that we do behind the scenes of typing things up. And so that would be a lot faster. But a really exciting development is the AI one, where we are, along with a lot of our hospitals, in fact, some have already implemented it, looking to trial AI ambient voice, which comes up with a clinic letter for you in the consultation that goes straight away after the consultation. So two parts to that. One is we know there's a challenge right now, and we're working to put additional resource in to get through the backlog and bring that time down. That shouldn't be that long. And secondly, we are looking at one particularly exciting digital option, which will certainly be part of the future.
I've got another question for you regarding this. When there's consultations and patients are told that their case will be transferred to, like, for example, the hospital in Guildford, shouldn't that come up on their NHS profile, the waiting times and where they are in getting an appointment and so on, and treatment? Because for some reason, some patients it's not showing up on the NHS profile. Like, do you guys have any leeway on that from your side?
JJ, are you asking if there's like times to wait that you could choose from? Is that the question?
No, because it's not showing up on some patients' NHS profiles. So you know when you sign in to your NHS app and you have referrals for Ashford and St Peter's, but any other hospitals that you're being transferred from St Peter's to, those are not showing up at all on profiles. And
on profiles?
Yes, within the NHS app. Is that because it's a different hospital to what they're assigned to, or are those hospitals not connected? Like Guildford Hospital and St Peter's. Is that why it's not showing up on an NHS app?
I'd have thought that portal was connected, James, Ruth.
I think I'm not conversant enough with how the app works to answer technical questions. I think all we can do is be grateful for the feedback, take that away and try and understand it. Yeah.
Okay, thank you.
Is that okay? And JJ, I know that you had some, say you mentioned some experience that you had within A&E.
Yes, unfortunately, I'm one of those people that hates going to the hospital. No offense to anybody. I extremely avoid.
No offense taken.
Because of through 101 services or through my GP, I've been told I needed to go into I think I can't remember what the name is called. It's a triage at Ashford Hospital, the one where you see a paramedic and they assess and then they tell you whether you need to go to A&E or not. So on both occasions, that paramedic has told me I need to go to A&E. And only under his instructions is the only reason why I've actually gone to A&E. Otherwise, I would avoid it by all possible means. No offense again. So when I have been there, I've also been to West Mid A&E, and I am telling you from personal experience, our A&E department is a lot more streamlined, a lot less chaotic, and the way you triage as well, so that all the ones that are not so urgent but can be go into one of those cabins for the minor illnesses. That's excellent work because you just half the work, and so that's how you're reducing the wait times. Unfortunately, with any cause of triage, if there's something urgent, you have to deal with it, and that's that's normal. But you guys are doing a brilliant job, and I just wanted to say to the A&E department, great work, and thank you.
JJ, I'm sure that's music to a number of people's ears. So thank you very much for sharing your experience with us. But I think we said nobody wants to go to A&E. So yeah, I have that experience. So I'm looking around. Do we have any other questions?
There was another one in the chat, John. How is the collaboration working with the new SAPB mental health facility, Silverwood, working?
Yeah, thanks very much for bringing that back, Becky. And that's from Leander, I think.
I think Jay might have his hand up to answer that, John, if that's okay.
Yeah, sorry, I didn't see the hand go.
Yeah, thank you very much, Louise and John. And very pertinent question, because since the Silverwood unit opened, we had some experiences that I'll probably describe as teething problems. With the best of intentions, 2 units operating on the same campus. We've learned a lot from that, and we've implemented some weekly catch-up sessions where we do a lot of learning, but also planning around some of the patients that do move across to use our services, both in the UEC emergency department, as well as in maternity. It's actually one of those relationships that is being looked at positively within the Mind and Body Project, which is a collaboration of all of the provider organizations within Surrey Heartlands. And what we are seeing is the Care Quality Commission, who have been interested in this work as well, have asked us to share a bit more of the work that we're doing, because they're seeing an improvement overall in terms of some of the incidents that used to come through to them. So I would say it's very much on the up, and I couldn't get a better summary of how people can get past problems if they're intentional about working together. That is really proving its worth in those terms. Thank you.
Thanks, Jay. And then I hope that actually deals with your question.
Yes, thank you.
Thank you. I think we're very well fortunate to have the that Silverwood facility on the St. Peter's side. It is an amazing facility. Yeah, very impressive indeed, actually. And to say that that's been created from scratch, as it were, to replace an out-of-date facility, I think it's all testament to what can be done. So I'm very conscious of the time. We've got 5 more minutes left. So I don't want to restrict any questions, but if there aren't any more questions, I could give you 5 more minutes of your evening back, which is always very tempting. So on that note, I want to thank everyone, our presenters and our guests this evening, for this this meeting. Really do appreciate it, particularly in terms of obviously the questions, and also but where you've got ideas, suggestions, and the feedback that you've given to us. As you can tell, there's lots of moving parts at the moment, and we've got lots to do, but I hope you've seen that the enthusiasm that we as a team have got for making change and transformation, etc. So thank you very much indeed, and have a great evening.